Thank you to everyone for joining. And of course, thank you to our speakers. We're really excited to kick off this webinar about exploring breakthrough treatments in metastatic breast cancer. So the Breast Cancer Research Foundation is the largest private funder of metastatic breast cancer research in the world. I'm really proud to share that this October, we announced $32.8 million supporting 86 projects across the world. And actually, we're supporting the largest global effort to study metastatic disease through our Aurora projects. So we are driving the advances that are happening today in metastatic breast cancer. So I am thrilled to introduce my panelists today, Amanda Quick and Dr. Joseph Sparano. So Dr. Joseph Sparano is the chief of the Division of Hematology Oncology and deputy director of the Tisch Cancer Institute at the Icahn School of Medicine at Mount Sinai in New York. And Amanda, board member of the Pink Agenda, was diagnosed with metastatic breast cancer at age 29. So let's jump right in. We have a robust conversation, so I don't want to waste a second. Amanda, you were diagnosed at age 29 with MBC, which is what we'll call metastatic breast cancer, also known as stage 4 disease. Can you tell us about your story?
Yeah, of course. And, first, I just want to say thank you for having me and shining a light on metastatic breast cancer. I think it's so important that we continue to have these conversations, especially for young women. It was 2021. I was back home in the Midwest, and I had felt a lump under my arm in the shower. Initially, I didn't think anything of it. I was in consulting at the time. I was working a lot of hours. I was like, you know what, I'm tired, probably nothing. Didn't really give it a second thought. 6 to 8 weeks passed, and, I get back to the New York City, and the lump is just much harder. It's immovable. And I remember talking to my mom, and she was like, maybe you really should go get that checked out. So I had gone to my PCP, my GYNO. They conducted, breast exams, didn't really feel anything. There were various tests, a sonogram, a mammogram. And at the time, I think the messaging was, you're very healthy, you're really too young to get cancer. There was nothing even really in the conversation about that. But my PCP had then called me, and she said, we looked at your blood work, and we're looking at your liver enzymes. So things like your AST, your ALT. And she kind of made a joke. She was like, were you drinking more during COVID? They're extremely elevated. I'm like, not more than what I usually would. She said, I want you to go get a sonogram of your liver. So I go to get a sonogram. From there, I get a full body scan, and they show that not only is there shading, in my liver, but also my left breast. I get a biopsy, and it comes back, and, you hear those words that you never want to hear of, you have cancer. I remember getting that call. It's still so fresh in my mind, walking down the street, just bawling, talking to my mom and saying, like, how had this happened? What did I miss? I felt like I'd done everything, quote unquote, right, ate healthy. I was a college athlete for a year. This was something that I truly had never expected. And I think to add on to that, later, as we're starting to see different doctors and we get the scan results back, they say, okay, you are de novo metastatic. At the time, I didn't really know what that meant. I assumed that I still get emotional about the story, as you can tell, but, I thought my protocol was going to be surgery, radiation, chemo, and then I was, kind of done with treatment. So I think the first doctor we saw, she sat down and she said, you have stage 4. There's really no cure per se. We're going to kind of just put you on different treatments. You're not going to be able to have kids. And, the average lifespan is 3 to 5 years, maybe. So we left that doctor, and we were like, wow, that now completely changes. If I thought I saw my life, my dreams flash before my eyes, then that was a completely different conversation. So we're like, okay, let's take a step back, kind of really take in that information. And it was, I still say guardian angel. I kind of shared with some friends and family. and we got connected with Mount Sinai. And we got connected with Dr. Sparano, which is like amazing. And we went and met with him, and the conversation was very different. He said, you know, we're going to treat this like a chronic illness. There's a lot of drugs that are coming down the pipeline, and there's like a lot of hope for MBC. Like, don't give up. We're going to take this a day at a time, but like, you can still live a very great life. So, that was kind of my initial story. I've lived with it for 3 years now. There's definitely been like ups and downs, but, I will say, because of research, my family, my friends, having the best doctor in the world, I tell everyone I can about Dr. Sparano as much as I can, has really helped me, still be here today.
Mm-hmm. Well, first, I mean, Amanda, I've heard your story so many times, and it never gets less chilling, but also the deep admiration I have for you to share your story, because I think that part of the fear with metastatic breast cancer patients is that you often don't see yourself. And so by putting yourself out there, you're giving other metastatic breast cancer patients someone to look at and have and be able to see themselves in. And I think that's what's wonderful about you being able to be so vulnerable and open about sharing your story. You shared that you were connected with Dr. Sparano, who's a BCRF funded investigator. Dr. Sparano, one of the things that's interesting is, I was diagnosed at age 36. We have Amanda, of course, diagnosed de novo MBC at the age of 29. These, while we're still sort of relatively rare in the population, the fact is that this is a growing trend, that breast cancer is impacting more and more younger women. And in fact, the recent American Cancer Society report highlighted that breast cancer incidence is rising more sharply in women under the age of 50. And in fact, women in their 20s saw the sharpest increase in incidence than any other age group. Can you let's ground ourselves into what's contributing to this trend? Why are more younger women like Amanda and myself being diagnosed with breast cancer?
Yeah, that's very new information that you just described, and it's disturbing. I don't think we have a clear explanation right now. There is also an increasing risk of colon cancer, particularly that's been noted in younger women and men, and it's led to a change in the screening guidelines. For example, for colorectal cancer, it's been moved from age 50 to age 45. So there's something going on. I don't think we have a full understanding. At least for colorectal cancer, it's been postulated that it may have something to do with alcohol consumption. And in that AACR report that you alluded to, my recollection was that they attributed about 13% of cancers to alcohol ingestion. When we think of alcohol, we generally don't think of breast cancer, colorectal cancer. We think of, say, liver cancer, esophageal cancer, and other types of cancers. But I think the jury is still out. We really don't know what's contributing to this recent uptick in cancer occurring in younger women and men of different types. I was likewise, shocked by and surprised by Amanda's presentation with metastatic disease, as our initial manifestation of breast cancer at such a young age. Having said that, it is the initial manifestation of breast cancer in about 5% of all women who present with breast cancer. So 95% of the time it's localized, 5% of the time it does present as more advanced disease. The more typical scenario would be, a much older woman who may have had a lump in her breast for a year or two and neglected it, not someone who felt something and sought medical attention right away, especially as someone as young as she did. Fortunately, she did seek medical attention. And my recollection of our initial encounter was that Amanda was offered chemotherapy as a standard of care. And at the time, which was not that long ago, right? It was 3 or 4 years ago. the classical thinking was that for women who presented with the disease that she had, the extent of disease that she had, that even though we had another effective therapeutic option, endocrine therapy, to treat the cancer, or at least endocrine-based therapy, that her extent of disease warranted chemotherapy. So what we didn't have a clinical trial for her at the time, but what we did have was information from other clinical trials that have led to the approval of 3 new drugs for the treatment of metastatic estrogen receptor positive breast cancer. And those were the CDK4/6 inhibitors, which at the time were palbociclib, ribociclib, and abemaciclib. And so we discussed that as an option, and we discussed those 2 options, and we made a joint decision that maybe we can try the CDK4/6 inhibitor and the endocrine therapy as an option to the chemotherapy, even though the consensus of opinion was at that time that chemotherapy seemed to be the default position. And she did very well on that therapy for a very long time. So the take-home message, I guess, is that clinical trials can lead to really dramatic changes in therapy. And I will say that since that time that we had our initial encounter and had to make that decision, there now has been at least 1 randomized trial where patients who had what we call visceral dominant disease were randomized to chemotherapy versus endocrine therapy plus a CDK4/6 inhibitor. It was called the Right Choice trial. And it turned out that the endocrine therapy and the CDK4/6 inhibitor was the right choice, that patients who were randomized to receive that therapy did do better than those patients who were randomized to what was perceived as a standard of care at that time, chemotherapy. So I think that's one example of how a clinical trial, an example of a clinical trial, number 1, and number 2, how it can advance our treatment and have real life implications for women facing similar situations.
Right. And I'll say you both touched on something that I want to hone in on, which is the advancement of therapy and the difference in being diagnosed with metastatic breast cancer today in the past 5 years than it was even just 10 years ago, and how different the prognosis is for MBC patients today and the advancements that we're making at such an accelerated pace. So Dr. Sparano, you talked about this class of drugs, CDK4/6 inhibitors. That is simply one of a series of new classes of drugs that have become available within the past decade. And in fact, we've had more novel therapies approved in the past decade than in the 30 years prior combined. So when we're talking about accelerating treatments and novel therapies to help MBC patients whose disease tends to become resistant to drugs and they need newer and different options, once one option is exhausted, that's what you're also touching on as well, the need for clinical trials to keep accelerating and creating more tools for our toolbox, where MBC patients have access to new drugs that would effectively treat their disease as they evolve. And one more thing that I want to hone in on is we've been talking about a BCRF. When I started here about 10 years ago, in 2014, the number of MBC patients was about 140 estimated, 140,000 in the US estimated. And this year, the estimated number of cases is 200,000. Now, one of the things that we talk about at BCRF is why is the number of women living with metastatic disease getting larger? But another way to look at it is that actually there are more living with metastatic disease, right? And so it's not just that there are more patients with MBC, it's that there are more patients living longer with MBC. And that's why there are more patients today than there were a decade ago as part of the answer. So I hope that that provides some hope and some sort of reassurance that we're making progress and we're seeing it happen faster than ever before. And you both have touched on your own experiences in making that happen. And Amanda, as a younger woman, specifically with breast cancer, we face unique challenges. And you touched on one where someone said to you, you can't have children. I mean, what are some of the things that you've been dealing with as someone at your young age?
Yeah, I mean, there's definitely a few. And, I want to always highlight, I think the thing that Dr. Sparano has done that's amazing is the focus on a quality of life. It's not just living with metastatic, but like thriving and like having a life too. I think the biggest challenge though is, for me, I can speak to my experience and some of my friends, but, MBC presents as, or can present as, an invisible illness. So typically when I go to work, when I'm walking down the street, you don't necessarily see me and think, oh, there's a cancer patient. So, I'm sorry, I'm a little bit under the weather, but when you do have, I think, some of those things like side effects, or you're super tired, or you're going through treatment, I think it's hard, or it can be a challenge for people to put the two and two together, to say like, okay, wow, this is someone who is kind of in this part of their life going through cancer, but then they're also trying to like work. For me, I love to travel, still travel, still do, some of those other things. And I think that's the big thing about changing the narrative about MBC, is that, and so long, I think in the media, in the news, in Hollywood, we see that patient who, is bald. I did recently lose my hair, but who's, bald, who's weak. And that's definitely just not, always the case. I think some other challenges too are, like you said, family. So for me, knowing that like, if I choose to have a family, it's going to look a little bit different. So adoption, or marrying someone with already a child, and not necessarily having the opportunity, with my fertility no longer really being available to me. So I think just the big thing though is, the biggest challenge is the quality of life, and thriving as you kind of go through some of these challenges, right? So I think it was interesting. Dr. Sparano's first NP, she gave me the best metaphor, and she said, this is corny, and you've probably never surfed. I was like, I took one surf lesson. But she said, this journey, it's going to be kind of like riding a surfboard. Sometimes you're like on it, you catch the perfect wave, you have that long chapter of a treatment, things are going great, but then sometimes you fall off, and it's going to take a while to get back on, or it's going to take a minute to like resettle, reestablish yourself. So kind of just know that there's going to be ups and downs, enjoy those really, really good moments, and then know that you're going to get through some of the tougher ones.
Well, that's a beautiful metaphor, if you will. And I
Yeah.
think it applies to a lot, right? That kind of
Yeah.
applies to life, right? Sometimes you're doing good, sometimes you're not. And then you have to get on. You don't have a choice. You just got to keep going. So I think that you touched on a lot of things. And I want to reemphasize the idea of the fact that younger women, especially as more younger women are getting diagnosed, especially under the age of 50, as women, as we delay family planning, like a lot of women who are diagnosed now are in those stages of life that the traditional breast cancer patient, the average age being 62, doesn't normally have to deal with, right? You don't have to deal with family planning at the age of 62. You're probably done with that. But for women under 50 who are still in the midst of all of that, or even in the midst of finding a partner, but being in a relationship, or what you were talking about, why quality of life is so critical. Because as the age of diagnosis becomes younger, those quality of life issues become more complex and need to be considered when we're talking about treatment protocols. So thank you, Amanda, for sharing that. I know it's hard. Listen, I have my son, but one of the things I gave up was when I went into chemo, my doctor, who, like you, I have that, patients have really special relationships with their doctors. I know. My doctor is also, she's like my person, who I say like she's my person, but she was so reassuring and said, you can preserve your fertility, but it's so scary. I didn't at the time, right? And that's still, to me, because I wanted to be in chemo right away, I said, I have to start treatment right away. I'm not going to wait to preserve my fertility. And even like, I love my son, I have my son, but it's still, to me, the most heartbreaking decision I've ever made. Like I still mourn the image of my future. That exactly what you were talking about, is the image of my future has now changed as well. But
right. And I think that's something that Dr. Sparano and I talked about, was like, isn't an option. And like, it kind of was like, okay, do you essentially, I might not be using the right scientific terms, Dr. Sparano, but, pump yourself with more hormones to try to
Mhm.
or some of your eggs, or do you just start treatment knowing it's already spread? So it's such a hard decision to be like, you know what?
Yeah.
I kind of grieve that part of my life, but we do need to get started with treatment.
Yeah, exactly. It is that grief process though, right? It's that grieving process for so many different parts of your life. So I do, Dr. Sparano, I mean, I have to talk to you about this because you published one of the most, I would say, influential studies in the past 5 to 10 years. The Taylor X study famously helped identify more women who do and don't need chemotherapy. Can you talk to us a little bit about that trial and the work? I mean, you have already touched on the importance of clinical trials, but that was a big one as well. Can you tell us a little bit about that study and the importance of it?
Sure, I'll try, and I hope you don't mind the sirens blaring
No,
in
we
the
can't hear
background.
them. We can't hear them
Okay.
here, so.
Before I get to that, actually, I want to, you know, call out Amanda's, you know, resilience and resourcefulness, because we had this discussion, and there are many women who can't have children for a variety of reasons. Her reason just happens to be the cancer diagnosis, but she figured it out. So, but and that's that's the right choice for her. But anyway, regarding Taylor X, right, Taylor X. So this was a trial that began with an idea about 15 years ago, 20 years ago, when a new diagnostic test became available that leveraged new technology called a gene expression assay.
Mm.
And the initial studies demonstrated that when you did this test on a tumor specimen that was already collected, so the specimen was already collected, it's in a lab and being stored. The specimen was sent to a central lab where what's called the RNA was extracted from it and analyzed and calculated into a score that was developed based on previous studies. And it was shown that this score, ranging from 0 to 100, provided prognostic information for recurrence that was independent of other known prognostic factors like the tumor size, the grade, and other factors. And that was important. Next important study was what was called a prospective retrospective study, where they took tumor samples that were stored in a bank from patients who had previously enrolled in a clinical trial, who were randomized to endocrine therapy alone versus endocrine therapy plus chemotherapy. And it was shown that overall there was about a 3 to 4% benefit from the addition of chemotherapy in this population. So in other words, for every 100 women who were treated, only 3 to 4 of them actually benefited from the use of chemotherapy. That is, their recurrence was prevented at least at 10 years out from the use of chemotherapy. When this test was then retrospectively applied prospectively to this set, it was found that about a quarter of the women who had the highest score had all of the chemotherapy benefit. So rather than a 3 to 4% benefit, there was about a 25% benefit in this group. And that was really very important. That was published in 2006. And so it was around that time that we said, okay, we have a window of opportunity because this test is out there, it's being used in practice, and we know this group of women, the 25%, really benefit. But what about the remaining group of women? Did the women who have the lower recurrence score benefit? And that's what the Taylor X trial was designed to address, to really address the uncertainties that still remained about the use of this test and how useful it was in clinical practice. So the trial included women who had hormone receptor positive, HER2 negative, node negative breast cancer accrued over a 4-year period between 2006 and 2010 throughout the United States, but also in Canada, Ireland, Peru, Australia. And the first results became available in 2015. And it was found that those women, the 17% of women who had a recurrence score of 0 to 10, who were assigned to treatment with endocrine therapy alone, did really well. They had a less than 1% recurrence. a recurrence of breast cancer with just endocrine therapy and all. So clearly, chemotherapy was not necessary in that group.
Yeah.
Next results became available in 2018 when we looked at the women who had a recurrence score of between 11 and 25, which turned out to be about 2/3 of women who enrolled in the trial. And it was found that, that there was no benefit for chemotherapy overall in that group. However, for the 1/3 of patients who had who were 50 or under, there was some small benefit from chemotherapy, and it was generally in the range in patients who had the highest recurrence score of 16 to 25. That led to changes in practice guidelines where we now could spare the use of chemotherapy more with much greater precision based on that information. A year later, we did additional analysis showing that although the recurrence score was important, the clinical pathologic features were also important and added important prognostic information. And then in 2021, we developed a new test or a new algorithm that integrated the information from both the recurrence score and the clinical pathologic features, the tumor size, the grade, the age, and the type of hormone therapy. And that test or that tool called RS-CLIN provided not only more accurate or reliable prognostic information about recurrence, but also could tell women with pretty good precision what the likelihood of benefit from chemotherapy was in their individual case, not as a population, but in their individual case. And around that time, we also learned the results of a similar trial called Responder,
Yes.
where women with a recurrence score of 0 to 25 and had 1 to 3 positive nodes were randomized to chemotherapy or not, in addition to endocrine therapy. That study showed actually results that were very similar to TAILORx, that postmenopausal women didn't seem to benefit from chemotherapy, whereas premenopausal women did have some benefit. And the higher the recurrence score within that range, the greater the benefit. And if you consider the totality of all of the information, what it's suggesting is that some of the benefit from chemotherapy may actually be simply due to the fact that it's bringing on menopause sooner, because the development of early menopause is a known side effect of chemotherapy. And there is now a trial that's ongoing called the Offset trial that's designed to address this question. So it's taking women with a recurrence score of up to 25, 1 to 3 positive nodes, or node negative and a recurrence score of 16 to 25, and they're being randomized to ovarian function suppression and an aromatase inhibitor versus that plus chemotherapy. So that study will nail down for sure what the role of chemotherapy is in that population of women who are higher risk. Finally, the last thing that's changed is that we now have the CDK4/6 inhibitors now have been approved in the high-risk adjuvant setting. We now have 2 that are approved, both abemaciclib and ribociclib. And so what I'm seeing now is we have women, postmenopausal women, mainly who may have 1 to 3 positive nodes, but have a recurrence score that tells us, well, they're probably not benefiting from chemotherapy, but they may be benefiting from the use of CDK4/6 inhibitors. So we do have this option for women who are at higher risk but may not benefit from chemotherapy. So you could see how the field has evolved just within the last 5 years since we got the main results from TAILORx available.
Yeah. Well, thank you. We're going to dig deeper a little bit more into some of these new treatments and therapies, because I think what you talked about just now, the approval of the abemaciclib and ribociclib in earlier stage high-risk breast cancers is brand new. I mean, really new. We're talking the ribociclib was just approved for early stage breast cancers, high-risk breast cancers, just 2 weeks ago, very, very recently. And so we are seeing a lot of drugs that usually start in the metastatic setting, and their success ends up then moving to earlier stage settings so that we might then prevent metastatic disease in earlier stage patients. And that capacity to target an individual person's cancer and improve targeted therapies is what's driving that improvement in survival for metastatic patients, but also for earlier stage patients as well. And we're going to dive deeper into this. But Amanda, I want to come back to you first. Number one, can I just tell you, I'm like giving you a hug, like I'm hugging you right now. Like I'm not there with you, but I'm hugging you. I'm hugging you because hearing you talk about all of this, like I love you so much, and I just want you to feel that and know that I'm holding your hand right now.
I appreciate that. Yeah.
And you didn't just, I mean, this is recent, right? Like this is not something that happened 5 years ago. I mean, this is still very much on the top of your mind, of course, but you didn't just sit back to receive treatment. You also took action. And in addition to being diagnosed with MBC and now managing your care, you joined the Pink Agenda to support research. Can you tell us what drove you to do that? Why go that extra mile?
Of course. And, first I just want to say between BCRF and TPA have been some of the most, welcoming, just like best organizations that I could have joined or been a part of as I go through this journey. But, I'll start with, I guess, a story. I know my dad's on, so hey, Dad. But, we were watching a game in the living room one day. It was the Chiefs. And I remember Patrick Mahomes, the quarterback, threw a pass to Travis Kelce in the end zone. And my dad stopped and he was like, guess what? I was like, what? He was like, I have an idea. He was like, you are going to be Patrick Mahomes and you are going to be the quarterback of your team. Like there may be, and my mom has said this too, there may be no cure on paper, but as many people as you can get around you, friends, family, the way that you eat, the doctor that you have, all of that is going to make a difference. So, the big thing too, I think with the Pink Agenda and the reason why, I just felt so inclined to get involved was first the education piece. Like I said, when I was diagnosed, I didn't even know what metastatic meant, and like really understanding at a deeper level what that would look like for care, for quality of life, and everything. And, TPA has, I'm a part of their education committee, and we put on programming throughout the year, specifically for young women. I think for me too, is when I was diagnosed, there was so much outpouring of love and support. There was family, there was friends, there were people, as you probably know, who were like, talk to my boss, talk to like my aunt's like great cousin. And that was so helpful. But I think as you talked about, a lot of those women were 60 or 70 years old. And I needed to find like my people, like other people who were 20 or 30, who'd been on similar drugs, who'd gone through similar experiences, who I could just have those conversations and say like, okay, come over. Like, I'm really struggling with this, like without the veil of like, I'm fine today, So I really think it was the education, the awareness, wanting to get involved, learning for myself, but then continuing to, also just build that team so that I could move forward. And, I really do feel like a part of my bigger purpose is to change the narrative around MBC and what it means to thrive with the disease. So I think TPAs and BCRF again have continued to do, a great job of that. And I don't think it's just on paper or just on the campaigns. Like I said, when I made the choice a few weeks ago to, I'm so sorry, I'm like under the weather, to, shave my head, like you were one of the first people. Kathleen gave me your number and she said, talk to Sadia. She can talk you through like wigs. She can talk you through what to expect. And like, you basically dropped, it was like one of your busiest weeks, it's our busiest month. And like you dropped what you were doing to answer questions, to like support. And so I really think even behind the scenes, people are so supportive and want to lift you up. And that's the type of organization that like, I really want to be a part of, and then hopefully continue to drive that legacy forward. So, they say worst club, best members. I hope, no one I know or women don't get diagnosed, but as young women do, knowing that they have like these resources to say, like, when you go look this up, it might be considered like a death sentence, or it might be considered really bad news, but like, here's what other people are doing to like still make the best of and the most of like their life.
Well, Thank you, Amanda. I mean, I think that what you're talking about also, that feeling, every patient I've ever spoken to has expressed that desire to want to help. And I think that's sort of what, I don't know if it's unique to breast cancer, but I've certainly found that to be the case with breast cancer patients, is that we all just want to help other women going through this. And I think that's what's been really like beautiful for me to witness, is that we all want to do something. Dr. Sparano, we talked about some of the breakthrough treatments. I want to get a little bit more specific on these sort of classes of drugs because, and I'm going to name a few just because I think a lot of the viewers who have had MBC or have been in treatment will be familiar with some of these names. So we're here to talk about breakthrough treatments for MBC, and we've seen the rise of entirely new classes of drugs like antibody drug conjugates, namely Enhertu, CDK4/6 inhibitors that we've been talking about, like abemaciclib or Verzenio, which is how I know its name, or ribociclib Kisqali, which is what patients who are getting the drug will know its name by, and immunotherapy treatments like Keytruda, which is now available to early stage TNBC patients as well, and Trodelvy, of course, which is still in the metastatic setting when it comes to immunotherapy. So from your point of view, what has been some of the most promising advances we've made in these last 10 years, and how are these new drugs moving us forward?
Yeah, the impact of these new drugs has been really remarkable. And I think we're just scratching the surface of what their potential impact would be. I mean, for my first 20 years in the field, we saw a lot of drugs that increased like the response rate a little bit. In other words, made the tumor shrink a little bit more, controlled the period prolonged slightly the period of disease control. It's only been within the last 5 years that we've seen this explosion of drugs that can actually improve survival, including the CDK4/6 inhibitors that have already been mentioned, the immunotherapy. We just learned a few weeks ago that the use of the pembrolizumab immunotherapy for triple-negative breast cancer, when used for earlier stage disease, can not only increase the proportion of the time that the tumors shrink and prevent recurrence, but are actually prolonging the survival. We just learned that. And the newest class of drugs, and a lot of buzz about antibody drug conjugates, which are basically smart bombs that deliver toxic payloads directly to the cancer cell and spare, to the extent possible, normal tissue. I learned about these when I was in medical school, but I learned about the concept, but the technology didn't allow pharmaceutical and scientists to be able to develop the drugs that we can actually use in people that can improve outcomes. And we do have those drugs now. We have at least 2 that are approved. I'll use their generic names: trastuzumab deruxtecan and sacituzumab govitecan, which actually are target different targets. One targets HER2, the HER2 protein, even in tumors that don't overexpress HER2 protein, even if they express low levels of HER2 protein, can be effective. And then another target called TROP2, which we don't normally test for. It's ubiquitously expressed on the cancer cells. So we don't have to test for it. We do routinely test for HER2. In both cases, those proteins that target those specific targets are hooked up or conjugated to a chemotherapy drug toxin that delivers the chemotherapy directly to the tumor cell. So those 2 drugs have been shown to be able to improve survival in both estrogen receptor positive and triple-negative breast cancer, and HER2 positive breast cancer as well. So those are game changers, and now we're doing the studies now, trying to move those drugs into the earlier stage setting. And they're generally associated with, they're not free of side effects, but they're generally associated with fewer side effects than standard chemotherapy.
Right. Well, I think what you touched on, this concept of where we're talking about antibody drug conjugates and targeting just the cancer cell, and even just the cancer, like the surrounding cells of that specific cancer cell, and not every single cell in your body, is so promising. as far as the future of treatment, because when we imagine what Amanda, you and I went through, or what you're going through right now with chemo, losing all your hair, like why do we lose our hair? It's because chemotherapy, traditional chemo, targets every single cell in your body, right? Including healthy cells, which is why we lose our hair and sometimes our nails and all of the things, right? But the idea that we might have treatment, and already people are receiving treatment that is only targeting their cancer cell and not every single cell in their body, I think is also a hopeful light in the future that we're moving towards, right? Which I think is really, I mean, I don't know, it blew my mind the first time I heard about it. I was like, what? One day just having treatment that'll only target our cancer cells. And one thing I want to talk about, I mean, we're talking about this very quickly, but when we talk about breast cancer truly is an umbrella term to capture very specific diseases, right? And it's a number of individual diseases that are quite different from each other, but fall under the sort of umbrella term of breast cancer. But they each need their own specific treatments to be particularly effective. And so that's what we're seeing that movement towards when it comes to why precision medicine has been so successful, because we're targeting specific breast cancers and an individual person's breast cancer. Just on Thursday, I saw an FDA approval for a new drug for metastatic breast cancer patients who are hormone receptor positive, but they happen to have an endocrine resistant gene mutation, the PIK3 gene mutation that renders them ineffective in receiving endocrine therapy. But now this new drug is hoping to solve that. And I think just that hearing this news, I feel like I hear it all the time, like the FDA just approved this new drug for metastatic breast cancer patients. We can't hear it enough, right? Because MBC patients need more and more options, but even that was promising. And you, Amanda, you've talked about sort of experiencing some of these developments and breakthroughs. How has that, knowing that research is sort of advancing at the same time that you're going through this, how have you sort of experienced that in your life?
It's absolutely remarkable to think that, when I started in 2021, there were drugs that were not yet FDA approved that, I've had the benefit of using, as well as other women. So I think, like you said, it really does speak to the testament of research and how many things are just coming down the pipeline. It's especially, I think, as someone living with metastatic, it's like every drug you kind of see as a chapter, and you want really long chapters, right? So, I've like sat in Dr. Sparano's office before and like cried because I'm like, wait, I only got 6 months on that drug. Like I felt like we went through so quick, but it always seems like he's like, okay, well, we can try this. We can try this. Like it seems like, thinking positively, having hope that there's always kind of that next thing that's coming down the line, and you have to find the thing that works best for you, your body, and obviously like, your subtype of cancer. And I think a few of the drugs that you guys have mentioned, I've been on Verzenio, I've, Enhertu, and that wasn't even around when it came out. Now I'm on Trodelvy. So there's so many, it's, no one I think ever correlates the words exciting and cancer together, but for me, it really is exciting to see the breakthroughs that are coming through. And then between BCRF, who's doing, bringing together world-class researchers for life-saving, research is awesome. But then I think to also have a doctor who, is willing to sometimes take some of those risks, like he shared with the story earlier. I think when I started, kind of the standard line of care was chemo, but he's been willing to say, okay, let's try this, or let's try this, or I've seen this in clinical trials. And I think that's, one of the reasons between those two things that I'm still here today and do have other options coming down the line.
Right. I think what you're talking about also is that quality of care, and the quality of care that you receive truly impacting your outcomes as well. And I should mention, I mean, I can't talk about breast cancer without talking about the fact that there are still really unacceptable disparities that prevent women of color specifically from benefiting from the advances that we've made and treatments that are readily available today. And one of the, it's evidence-based in the fact that Black women specifically are 38% more likely to die from the disease than white women. There are multifactorial reasons behind why that's the case, but also, of course, it's how just tumor biology and combined with social determinants of health and many other factors come together, including representation in clinical trials. And sort of what you were talking about, Dr. Sparano, is the fact that clinical trials are what drive new treatments. We have to make sure, and one of the things that BCRF through our health equity initiative is doing is ensuring that there is proper representation, proportionate representation in clinical trials for different races and ethnicities, also specifically for Black women, to make sure that the treatments that we're developing actually work. It actually works for all populations of women. So I think, of course, that's one of the things that we're actively working on right now. And I'll say we fund the translational breast cancer, the TBCRC. And I'm sorry, I know the acronym, I'm going to say it wrong, but they fund clinical trials throughout the country. Is one of the largest clinical trial networks in the US. And so far, the TBCRC in the last couple of years have reported representation in all of the clinical trials, specifically for Black women. So we're really proud of the fact that we made an active decision to require that, and it's happening. So we're hopeful that that's what we're doing for women of color, improving outcomes by ensuring that treatments work for women of color. So there's one question, please feel free to submit questions, but we did get a question around Dr. Sparano for you. We talked about sort of, and Amanda, you've touched on this again, about choosing different methods of treatment. And this question is around how long should clinicians try to avoid chemo, and is there any benefit to aggressive chemo earlier on in metastatic breast cancer? And so I think you've sort of answered this, but let's sort of get to that question again.
Yeah, it's a difficult question to address generically, because every situation is different. There definitely are circumstances where chemotherapy can be useful, and I didn't want to give the impression that it's something that it's no longer a useful tool. At one point, not too long ago, it was really the go-to option or the best option. And fortunately, neither is the case anymore. So, but for some people, it may be the best option. And so I would just caution people to not to not to have the pendulum swing too far in another direction, where to say that chemotherapy has no value. It definitely has a value. It definitely saves lives, both in the early stage setting, where the 40% decline in breast cancer mortality that we've seen over the last 40 years is in part related to the more widespread use of adjuvant chemotherapy in women at high risk to prevent recurrence. And in the advanced disease setting, it can definitely help to prolong life and palliate symptoms. So there definitely is a role for it. But fortunately, we have other options that we can go to often before that we resort to chemotherapy.
Okay, and I'm going to read some of the questions. A lot of them, of course, are for you, Dr. Sparano. But one question was, and I apologize, I actually have not used this term out loud before. Oligometastatic breast cancer be considered a subtype of MBC, and can it be treated with curative intent?
Yeah, oligometastatic disease refers to a woman who may have between, say, 1 and 5 sites of metastasis. Usually it's between 1 and 3, sometimes just 1. Oftentimes we approach that, and they may present with, say, 1 site of metastasis and a localized cancer. So we generally approach those women aggressively and treat them as we might treat someone who presented with just the primary breast cancer. So usually with systemic therapy and local therapy, which might include surgery and radiation. And in some cases, radiation ablative therapy, in addition to systemic therapy to address all sites of disease, including sites that we can see and that we may not be able to see or detect through scanning. We will also may deliver local therapy to those sites of disease, those limited sites of metastatic disease with radiation.
Gotcha. And actually, there was another question that asked, can you help explain why some women do not receive surgery to remove a breast lump after being diagnosed with MBC?
Yeah, there have been 3 randomized trials that have addressed the question to does doing surgery for the primary tumor, removing the primary tumor, have any impact on outcomes, with the main outcome being survival. And the totality of the information would suggest that there's no impact on survival. However, again, these trials were done, the most recent one was started in 2008 and ended accrual, I think, in 2014 or thereabouts. So these trials were not done in the era where we have our best medications available. And at least one of the trials did indicate that the local therapy could help improve local control of the disease and obviate the need for any, subsequent local therapy, or at least delay it. So I think there still may be a role in selected circumstances for addressing the primary, but I would say that the more effective our systemic therapies become at addressing all sites of disease, the metastatic sites and the primary site, that the less dependent we may actually ultimately become on treating the primary tumor as well.
And we received another question about if there are new treatments or research coming out for people that show resistance to a lot of treatments out there. I think what this person is asking is about drug resistance and how we approach drug resistance in some MBC patients.
Yes, typically, as we develop new and more effective therapies, the drug development issue becomes more challenging because typically the setting where we would test drugs would be in patients who for whom therapeutic options have been exhausted, or there may not be, an established standard therapy. So we're tending to test these drugs in what we call phase 1 trials, which are first in human trials, where we're trying to establish what the right dose of the drug is, not necessarily whether it's effective, although we often see tumor shrinkage and efficacy when we're testing these drugs in the phase 1. Once we've established what the right dose and schedule is, we do a phase 2 trial, typically, where we take an established dose and schedule that's been identified in the phase 1, and we test to see how efficacious it is, whether used as a single agent or in combination with other drugs. And then once we've tested drugs in the phase 1 and 2 settings, and we've shown we know what dose and schedule to use, we can establish its safety, and we know it has efficacy, typically we will then do what's called a phase 3 trial. And these trials generally involve testing a standard therapy versus a new therapy, or sometimes testing a standard therapy with or without the new therapy. So that's how the drugs are typically developed. And then if we see promising activity in the metastatic setting, then we move it into the early stage setting. But I guess the take-home point is that the more effective our therapies are becoming, the more options we have, the more challenging it is to identify the right patient population to test new treatment options.
Right. Well, I'm going to leave one more question, and this question is actually for you, Amanda. You mentioned some of the drugs you are on, and we have someone who mentioned that they're moving on to Trodelvy and was curious about the side effects and how you've coped with them.
Yeah, and I had these same questions too. Dr. Sparano was, nice enough to introduce me to one of his patients who had also been on the drug. I know it can always be nerve-wracking to just start something new. But for me, I'm on cycle 3, so it's a 3-week cycle. You go in for 2 weeks, or you have the infusion for 2 weeks and then 1 week off. For me, thankfully, I haven't had too many side effects. Like I mentioned, I did start losing my hair, have to shave my head, but for me, it's been just some fatigue. Thankfully, it's not like 12, 15 hours sleeping, but I do think taking time for that rest is super important. But haven't really had as many of the, GI issues, that are sometimes mentioned, or anything else. So I think right now, like I said, super grateful that so far it hasn't been too bad, and other than, some bloating as well.
Mhm. Thank you. I know side effects are always that one thing you're like, wait, so what about, I'm glad I'm treating my cancer, but how is this going to affect my quality of life, right? It comes down
Right.
to
Or
like,
someone will have none. And then my other friend was like, I was running to the bathroom at work every 2 hours. So
yeah.
it's definitely person to person. So
Listen, I'm on Verzenio. I'm very familiar with many side effects. So
yeah.
I feel you there. I think, we're coming to a close. And first, I just want to reiterate how deeply grateful I am for your generosity of both time and spirit in sharing both these deeply personal stories, but also your expertise, which is, I mean, between the both of you, I mean, Dr. Sparano, one of the most sought after doctors in New York, I would say, and perhaps one of the,
Yeah.
yeah, in the world, I would say. So again, I feel deeply honored that you joined us in this conversation. And Amanda, similarly, I feel very honored that you reached out to us and wanted to talk about this. I think you're doing a tremendous service to patients who need to see themselves in others, right? And so I applaud you for that. And I will leave on a note of hope, just that I hope everyone takes away from this conversation that the perception of how we understand metastatic disease is changing every day. And every day that we're advancing and improving treatments, it is absolutely changing. And Amanda, you're a beautiful representation of that. And I think Dr. Sparano, you're just another representation of that. The idea that we're advancing treatments that will hopefully not just to extend lives, but to extend lives to live long, beautiful, wonderful, fulfilling lives as well. So thank you both again for joining. And I hope that our viewers, please, if you have more questions, please feel free to email us at bcrf@bcrf.org, and we'll try to do our best to answer them. But also, please visit our website. We have tremendous resources of information on there, a wealth of information on there that you can find a lot of answers to. So thank you again, Dr. Sparano and Amanda, and please feel free to jump in if you have any last words to share.
I would just like to thank you and the BCRF for all the great work that you do. Not only the funding that's been provided to me and the organizations I represent over the last decade or so, but for supporting, activities like this.
Thank you. Thank you, Dr.
Yeah, this was amazing. So thank you for all the work you do. And thank you, Dr. Sparano, too.
Appreciate everyone's time. Thank you. And I hope everyone enjoyed.